Welcome to the Who Knows This podcast, where I track down in-the-trenches experts to answer questions that we all want the answers to. I'm Sam Besnick, and I'm a veteran in working with people with chronic aches and pains by the way of massage therapy, exercise, pain education, hypnotherapy, and lifestyle education. Today, we're going to talk about dizziness and vertigo that is being driven by the cervical spine. So let's get started. All right, I'm going to read a quick bio here to introduce you to our upcoming guest. Dr. Harrison Vaughan is a physical therapist who specializes in treating musculoskeletal injuries and spinal pain, both acute and chronic, and he has particular expertise in the treatment of orofacial and craniocervical disorders, including cervical dizziness, which we're going to be discussing on this episode. He co-owns PhysioFit of North Carolina alongside his wife Danielle, who is also a physical therapist. And his clinical interests are concentrated in manual therapy and specific therapeutic exercise of spinal disorders, and has extensive postgraduate training in manipulation of the spine and the extremities, including instrument-assisted soft tissue mobilization and dry needling. Additionally, he furthered his career by graduating as a fellow in the American Academy of Orthopaedic Manual Physical Therapy in 2015. Dr. Vaughan teaches an advanced cervicosensory motor approach alongside his wife, Dr. Danielle Vaughan, in their course Diagnosis and Management of Cervicogenic Dizziness, nationally and internationally to other healthcare professionals. He resides in Wake Forest, North Carolina with his wife and two children, Reagan and Cora. So I want to introduce him here in a moment, so let's get started. All right, so here we go. Harrison, thank you so much for being here, for being on the podcast. This is a very exciting topic. Anything to do with the cervical spine in particular is exciting to me. It's definitely a personal interest I have. So thank you for taking the time to be here.
Well, absolutely. It's a pleasure to be here. This is a big interest of mine and one that we've sort of narrowed down and hopefully be able to help others, clinicians and patients alike all over.
Yeah, and I'll give a little background to those of you out there, listeners. Over the years, I'm sure as every health practitioner, regardless of what it is that they do, whether they're a therapist, doctor, personal trainer, I'm a clinical massage therapist, you run into a variety of different types of issues with people, and some of them you're able to help with, and some of them come in with situations where they have a ongoing or long-term health issue that they're just desperate with and having difficulty. And in this case, I think one of the ones that a lot of people struggle with, and in particular I do, is helping people who tend to have ongoing issues with things like vertigo. And of course, as we're going to talk about, the distinction between vertigo and cervical dizziness. And that one of my clients had been doing some internet searching and stumbled upon your book, and give, of course, credit to your wife as well, who can't be here today, yeah. Danielle. But you guys have written this book, and I looked at it and I'm like, I've never seen anybody write about this. I'm sure somewhere you dive into the literature, you see things, but I bought it immediately and was blown away at the level of specificity around this topic. And, it had algorithms and all sorts of cool stuff that, of course, is even over my head, but it was enough to be like, this is extremely valuable. So I asked him, Harrison, to be on here today to talk about it. So thank you so much for writing that book. And it's like, I think this is going to be such an invaluable resource for people once they know more about it. So that's what I want to chat about today.
Perfect. Yes, let's roll.
All right. So first of all, let's chat about something as a big picture topic here is that, the book in particular, and I think people get confused about this. And as I was reading it, as I start asking questions of clients as well, is this big picture distinction between cervical dizziness and actually vertigo. So can you help us understand the difference between these two things?
Yeah. So generally speaking, if you just ask someone about dizziness, it can mean different things to different people. And that's a little bit different. That's a little bit broader versus if you ask someone vertigo. Vertigo is a little bit more defined definition of the room spinning around you for the most part. And vertigo itself usually leads to people always probably hear of BPPV or positional vertigo. It's probably the most common type. And there are some typical signs and symptoms associated with it of maybe looking down, rolling over a bed. You just get a short duration, like, whoa, the room is spinning around me type of thing. That would be considered vertigo. So generally speaking, that is in itself. And when we talk of cervicogenic dizziness, we use the word dizziness. And we kind of use it broadly. If you look into the literature and you go back, some cultures still use the word vertigo, especially in the Eastern cultures, and that's because they really don't have a difference in the terms like we do here. So we like to use the word dizziness because someone who is experiencing dizziness or symptoms from the cervical spine, it's very rare that it's actually room spinning vertigo. So that's a big differentiation for individuals, and because if it is something of positional vertigo, it's almost a totally different avenue you want to go down in terms of treatment. We have gold standard treatments now that are very, very effective. So the cervicogenic dizziness component is kind of a separate entity almost, even though you could have both aspects. It's just something we call a double entity.
Yeah, that sounds where that's where the complexity is. And of course, I am as somebody who's into linguistics, is like the distinction of those terms and the nomenclature is really, really important, because for that reason, it's a different set of pathways of how you might treat that. So just for my own clarity, so if I had vertigo, I would just be sitting here and the room would feel like it's spinning around me. Is that correct?
Yeah, a lot of times it could be at rest or it could be with positions. And the most common positions are most people describe are like laying in bed. So you're going and your head is being tilted back or rolling over in bed. Those are kind of your big ones, and looking down sometimes as well. So if those are your big time descriptors, but in some individuals, if the brain is really getting some abnormal signals, you might be sitting there and the whole room is spinning as well. And that happens. We do see that as well.
Well, what would you say is kind of like the hallmark of cervicogenic dizziness that right away triggers you to be like, this is cervical dizziness versus vertigo? Is there something that really triggers you right away when you think about that?
Yeah, so we'll break it down. Typically, I'm a big descriptor type of person. I allow the individual to tell me what they're experiencing, because when you talk about dizziness or you talk about something that we can't see, we have to really interpret what someone is giving us. And this is really kind of my wheelhouse, and something that I feel like healthcare professionals ought to be able to do is listen versus just kind of going down XYZ because it's most common. So someone who is probably going to have more of a cervical dizziness standpoint, they will probably describe it more of a lightheadedness. Sometimes it could be even considered like, I'm just unsteady. Something's just not right. Or drunkenness is a term that some individuals would utilize. And we have that in the literature of differentiations between BPV and cervical dizziness. So when someone's kind of describing, if they say, no, the room's not really spinning, it's just something not quite right, maybe more lightheadedness or something, that is one of the first descriptors that allows me to kind of keep going down this pathway.
Gotcha. So yeah, it's not one thing, your brain goes right to the diagnosis. It's trying to gather information about the person's experience and under what circumstances it occurs and all of that stuff, right?
Exactly. Yep.
Okay. And then, so one of those things that pops in mind also is, again, how complex this could be, is that like, how does that relate to issues like, for example, POTS or having low blood pressure issues? And in the book, you talk about this a lot, which is that one of the most common reasons for some of these types of symptoms is actually side effects of the medications that people are using.
Yeah. Yeah. So whenever you think of cervicogenic dizziness as a diagnosis, for the most part, we've got to rule out some of these more common causes. And typically some of that could be questionnaire stuff. So it is medication. And if you're on a ton of different medications, there's a ton typed out there. It's not like one specific. It could be a component. Sometimes by the time someone gets in our office, they've kind of figured that out a little bit more, or there's a temporal relationship. But that's always something that a clinician should almost have in the back of their mind, like, yeah, what if we tweak this a little bit? Or a physical therapist can't tweak it, but talk to your physician about it.
That is probably, in my opinion, is less common. I mean, people oftentimes are very unaware of any side effects that medications are causing. So, and that's kind of concerning, considering that they've been dealing with this kind of an issue for a long time, or whatever it is that they're dealing with, and nobody has questioned or looked up, online, whatever Medscape or whatever website you look at, and looking at the actual side effects that the medications are using could literally be a strong contributing factor.
Yeah, absolutely. I kind of break things down in my clinical practices, things we need to upshift and things we need to downshift. And downshifting could be, you know, do you have, say, a high sodium diet that's going to put you at risk? Or do you have certain things that which could be medication while we're on it? I mean, medication could be like something downshifting that, hey, let's address that before we go in and mobilize the neck and do positional tests. And it helps really what it helps do, we still do upshifting things, but it really helps the individual kind of really think of the body as a whole system, as an entire entity of like, oh, wow, I didn't think about that. And it kind of helps do some research and really gets them in control of, why are they on that medication to begin with? Are there other strategies that we can do? And that's not a short-term type of thing. That might be like a long-term change with some things that we might do with them, but absolutely a big component.
And I'll back up and ask you about the sodium. So you said that a high sodium diet can be a contributor to these types of issues as well.
Yeah, and not just cervical dizziness. I mean, just generally vertigo. We tend to, I'm a big component of almost connecting the dots, going backwards and helping someone if they have a flare up. Let's say it's like, whoa, I was better yesterday, but 3 days ago was really, really bad. Like, what is it? And we kind of connect the dots a little bit. And they're like, oh, well, maybe I had a lot of chips and salsa at a restaurant or something of that nature, right? And or just prepackaged foods, traveling, not eating as well, and we find out, oh, that could have been a component of this pie chart that might sensitize the system and cause some sort of flare.
This is what I really appreciate. And the reasoning for this podcast was helping people understand the complex nature of a lot of these issues, is because a lot of times I think, of course, and hopefully we're starting to move out of this excessive amount of structural biomechanicalism that occurs in these fields and understanding that multiple systems can be interacting. And, in particular, we talk about the cervical spine and you brought up the sensitivity. And that's where I want to dive into here soon, is that what is actually happening that is contributing to that sensitivity. And it's not purely a structural phenomenon.
Right.
So let's talk real quick about, we talked about why it's important to differentiate between cervicogenic dizziness and other origins. And of course, that is because the treatment might be much different. But in particular, in reading your book, and you had brought this up, is that there seems to be a strong degree of skepticism that comes toward these issues, dizziness and vertigo, being originating from the cervical spine. And I would imagine this kind of ties into what you talked about, is it's almost like cervicogenic dizziness, if I understand correctly, is almost a diagnosis by exclusion, right? So doing all of these other things and figuring that out. So, but why is there so much skepticism that comes in this topic?
Well, yeah, this is probably it's interesting. People are like, well, wow, you're going to want to teach and have a knowledge on something that's so skeptical, and it's a big division between fields with neurology and components. And I think one of the biggest things that it comes down is two components. One is we don't have like a specific test that we do have some things which we could dive into, but we don't have like a blood value test, or we can't put you in an MRI machine or something of that nature. And a lot of times physicians in particular, like really like that. We need some objective data, these data metrics that we kind of go through. And because they're like, oh, well, lightheadedness is not good enough for me, right? Because that could be lots of different things. And that's why we create these algorithms to help the individual really make this diagnosis. So I think that's first and foremost, is that that's a major component. Another one is that some people may not have a lot of changes in the neck from a degenerative standpoint. There's no temporal relationship of someone with like, wow, look how bad your arthritis is. And they're like, well, I'm not dizzy. And then some people barely have arthritis and they're dizzy. And we can talk about why I think that's a little flawed reasoning, but that's pretty much number two. And I think it comes down to those major components. And it really comes down to the third component is the more skeptical somebody is something they can't help with. We refer people to neurologists back and forth, or audiologists and different things. But if that is something from the cervical spine and the neurologist, like, well, I can't help you, like, then it's almost saying, well, it doesn't exist.
Right.
Whereas like a physical therapist, a chiropractor, maybe an acupuncturist, sometimes massage therapist, like, one of the biggest helpful factors is some sort of manual therapy to individual. And that's something that we do. And that is really our cup of tea, because there's not medication that you can give and things like that. So I think those are three major components. And it almost can, as I did a telehealth with someone recently, and he talked about this, and he's like, his neurologist like, no, this doesn't exist. This is bull, this and that. And the guy wound up seeing a chiropractor, and he's like, it changed it. It was only like 3 days, but it changed it. There's got to be some sort of relationship. And it was almost kind of blown off. And so I think for the consumer out there who's dealing with this, it's almost sometimes who you see that can make a difference too. And you can see lots of people. We recommend having multiple consultations for something very, very complex, or if someone doesn't really specialize in this. So I think those are your major factors of someone seeking out if they can help you, if it is a component.
Yeah, I think one of my pet peeves that just popped up there is the issues surrounding manual therapy. And of course, as somebody who's a manual therapist with soft tissue therapy, there's so much change that's happening in these industries right now, especially a very aggressive approach toward manual therapy. I'm sure you've seen a lot of it as being useless and studies saying that it doesn't work well. But and the thing is that we've all seen it work when nothing works. So in some cases where you do something with someone's neck and there's maybe no mechanical reason why that therapy would make a difference, and it makes a huge difference. And I think they're still struggling to really understand, because manual therapy does so many different things, what part of that is actually helping people. And, that's something that I struggle with in particular, is that, if you go to a neurologist, you go to I don't know, your cardiologist or whatever, and you're ruling these things out. And then, of course, they're looking at it, you're right, and saying, well, there's nothing here. It's in your head, or whatever, dismissal kind of terms that they'll use. And then they go see a practitioner like chiropractic or whatever, right? And then some kind of technique works for them. Then what does the clinician do with that information? Because to them, they read the research over here that says, oh, manual therapy is useless. And, I couldn't help this person. And now, like, rather than trying to dig a little bit more to find out why that might have worked for that person, it just kind of, they did delete it. And then it never moves forward. Like, people don't figure out, well, why the heck does manual therapy to the neck actually help somebody with this type of problem? So of course, that sounds like a perfect scenario why somebody would be super skeptical of it, right?
Yeah. And even as like the young physical therapists are coming out, they're hearing exactly what you're talking about. Like, don't, manual therapy is short term and doesn't do this and that. And there's truth to that. It's interesting, and something we always talk about in our treatment approach is that out of pretty much any condition that physical therapists could see, we actually have systematic reviews and meta-analysis which are higher level research based off of really high level randomized control trials, that actually manual therapy is like one of the first approaches you do. So it's interesting. This kind of diagnosis itself is it's sort of sitting out on its own a little bit. So we do have some exercise approaches that are effective as well. But if you just kind of take it from the top down, that's the interesting thing. And I think that's where a clinician, whoever you're seeing, kind of needs to be aware of that versus the whole picture of just manual therapy is not great. Don't do it at all.
Yeah. And so I definitely want to talk about your protocols, but a couple of additional frames I want to set here is that, almost as always, as the individuals who are dealing with complex situations, as therapists, you probably have a procedure by which you're gonna address some of these other factors. So, and knowing, just because I'm in the field, how difficult it oftentimes is to collaborate in a really seamless fashion with other types of healthcare professionals, my question is that in your raw experience in working with patients that are coming to you with these types of issues, how or what is the frequency that you would actually see that when somebody comes in, they have really worked through some of the algorithms on the top end of your model, which they've been ruled out for things efficiently? So for example, if somebody comes in and they say, well, my back hurts, and I'm going to go, well, how many practitioners did you see? And they say, well, 3 or 4 people. And then, the question is, okay, am I just going to take at face value that those practitioners have really ruled these things out? Or do I
Yeah.
unfortunately need to go through them again to make sure that they have been done properly? I think you know what I mean. And that's always the
Right.
$1 million question, which is backtracking through other people's work or just taking it as if that's the case. But how many people are starting off from a point where you're like, all right, you're ready for this work versus I need to kind of reestablish and get you out to see the right professionals to rule these things out?
That's a great question, and I don't have direct numbers on that. Uh, the majority of people wind up seeing me have been through the gamma, because and it is kind of nice because then we sort of know they've been through that. But we created like a clinical diagnostic process that's just going to kind of rule out things that aren't. Uh, um, aren't the cervical spine. And one of the biggest things, like if someone has come to me and they're like, say they've had MRI, all that looks good, the vascular system looks good. We actually make sure that their positional vertigo is cleared even almost before we dive deeper into the cervical spine. And that's where, the vestibular therapists are kind of a big component as well. So I don't, unfortunately, I don't have a great amount of percentage there, but I always, just like you, I mean, you never know, what someone has been assessed if it's a clinical. I mean, that clinician or doctor could have been in a rush that day. Now individuals go and, we're in the COVID pandemic era and everything is COVID and they don't, nothing else is being spoke of. So we kind of really do make sure that we go through the process and I think that helps the person realize like, all right, you're right. You think there's something component. Let me just confirm that this is the major thing. And also what it does, you couldn't have just the neck as a component, but almost a bigger pie is that there's other things as well, maybe some issues with the inner ear or the ocular system or previous concussions, whiplash, and that almost helps us determine, prognosis and things. And so it really helps give a bigger picture for the individual.
Yeah, I love that, and it's coming through exactly how it really is how messy this process is in terms of how many different things that can collectively be contributing to this. But I also try to field those questions because some of them, admittedly, are my questions where I always want to ask. I'm just like, wow, I wonder. I mean, and of course, you have a good network of professionals around you. The longer you've been doing this work, that you trust that if I send somebody to this person, I know that they did an accurate job of assessing this. But of course, we do see those things. And in particular, when it comes to the neck is, in my opinion, quite complicated because of its relationships to the jaw and everything else. And there's a lot of neurology happening there. And the specificity of the testing, as you outlined in your book, for those of you, the Cervicogenic Diagnostic book, and looking at the really specific tests that you would do, for example, testing the upper cervical spine and, doing provocation tests, if you do those, you really not only have to know how to do those tests, but you also have to have seen enough patients to know what is normal and what is not a normal test. And that also becomes a little bit challenging too. I think that, even when you learn any kind of testing processes, you might know, okay, well, this is how you do it, but like determining the results becomes a little tricky unless you've seen a lot of bad cases, because then how bad it is. So I'd imagine in your trainings, that's probably one of the bigger things to do is to teach therapists how to properly do these kind of exams to get accurate information. Yeah.
Yeah, absolutely. Because I always tell people, if you push hard enough on somebody, you're going to create pain, right? And so you really need to kind of take the data and interpret it correctly, and almost have the thought process in the brain that, all right, I want to make sure that the information that is being communicated between the patient and myself is accurate information. And I'm not just feeding what I want out of it. I don't want to say this has got to be it. Let me make it in my brain. So yeah, the training from somebody is really some of the symptomologies that we talked about earlier it's a good way to almost dive down that pathway. And then the palpatory exam and some of the movement exams, which we talk about, it kind of can just put the cherry on top a little bit. And in the input, I'm a big advocate of interpreting what the signals are to the patient. So someone's like a signal goes to their brain. and the brain goes to their mouth and tells me what's going on. Because I can't tell you that you are getting a lightheadedness sensation or if this is giving you a headache. Like we can't see that, unfortunately. And so that's like my MO through my framework is interpreting the data, and that way we can provide a very specific treatment approach as well, based off of what the nervous system and the muscles and joints are telling us.
Well, there you go. Actually listening to patients and using their feedback to help them. Amazing.
The simple stuff that just doesn't happen anymore.
Well, let's talk about some of those actual tests that you do, kind of diving into some of the structural stuff. And how do you categorize the physical tests that you would do with people? And what are some examples of what you would do?
Yeah. So generally speaking, the way we would firstly start the examination if things are heading down direction is I do a movement exam, a range of motion exam of the neck. And I not only look and see where, if it's painful to the individual, if they have a lack of range of motion, but the actual detection of anything otoneurological, such as dizziness, could occur. And that's almost like the biggest cherry on top. So for instance, in cervicogenic dizziness, looking up is probably 60 to 65% of the cases. Looking up is going to precipitate some sort of symptoms. And we do have rotation with a few of those as well. So those are your major two. So if anyone says, I'm looking up to, wash my hair in the shower or to look at a plane go by or something like that, and you get an immediate onset of, whoa, I'm a little unsafe, I'm a little lightheaded. That's a big indicator. That's more of a hands off, but it kind of is just a big indicator of interpreting the information from a wider zoom, and then we eventually go into a lower zoom. So I would say majority of the time, the patient is going to experience something positional, because cervicogenic dizziness is a positional test. So it's when you get into position, and usually the latency is very short, very brief. And so meaning when you go up, it's going to come right away typically.
Okay. And a question that's going to pop up here too, man, this is also just so good. And because you're looking at this all the time, what I was taught in particular is that, of course, most of the therapeutic work is always ill-advised to take patients' necks toward extension, just because of the increased risk of the vertebral artery. But in particular, most manual therapists are pushed to almost be conditioned to be terrified of straining that vertebral artery in case we cause somebody to have a stroke. And those of you out there, you might have heard about this before. For example, that, I don't know, what is it, 1 in a million chance that somebody has a stroke or tears the vertebral artery as a result of chiropractic adjustment. How often do you see vertebral artery issues, or have you seen? I'm just curious in terms of like, how common is this, and how really afraid should people be about that?
It's very rare. Typically, the way we look at it now, and this was some of my fellowship work, we actually have a paper out on this, of differentiate between a spontaneous dissection and what we call like a mechanical dissection. So like, say you come in my office and you're like, I had this, woke up and the back of my head is just killing me. This is a different type of headache I ever had. I'm feeling dizzy associated with it. A clinician ought to be a little bit more like, something's kind of not right, because the signals that are coming from the tunica adventitia, the actual arterial system, is going to be almost more of a threatening signal than some of these other stuff. So generally speaking, the way we look at it is that the higher propensity of someone having something is spontaneous. So they come right into your office, because they could go to the ER. Right. But for some reason, let's say they trust you and you've treated before, or you have, hey, I treat dizziness on your website or social media, and they come into you. Like, that's the first and foremost, we just need to make sure something's not happening in the moment. Because that's a higher percentage of people, because that stuff happens all the time. And really, the understanding now on any ill effects of manual therapy, chiropractic, we have research on massage, or even cupping, or that people do have a stroke, unfortunately, even after some of those things, is that the thought is that someone was coming in with vascular stuff, and all we did was almost like kick it a little harder, where in fact the diagnosis process should have been like, I shouldn't do what I do. We need to send you to the emergency room and anticoagulants and have assessment. So I like to take it from that big picture, because I don't want people to be scared, but I don't want people to be completely unaware that happens, because that does happen. Like you said, that is almost a big afraid factor. I think we have a lot more good case control studies, a lot of them out of Canada, and determining the dots connecting backwards. If someone goes to the hospital, they connect the dots backwards, like, oh, well, someone was having a stroke here, but they went to the primary care first, or they went to the chiropractor, and there was really no difference in how they ended up at the hospital emergency room. So the thought is, primary care typically isn't going to manually mobilize the neck. And so we thought, well, maybe those individuals just missed the proper signals that actually should have sent them to a different individual. And that would be a spontaneous dissection. Very rare. Luckily, I've never even personally ran into that. That's part of our algorithm and part of my fellowship work we wrote up, and I've been just very fortunate because it is pretty rare. There's some really good case reports out there of that, though. But then you do have what you're even thinking of, a mechanical, like something that actually can disrupt it more, and that could happen. Absolutely, we have research that does happen, but the probability is low for that. It's obviously a little higher if someone was coming in and it was something vascular in nature, and all we did was precipitate a thrombus that goes further down the pipeline that gets smaller and smaller, and that's eventually leads to a stroke, and not just signals. The body was giving you signals like, I have a headache, I have dizziness, I have nausea, and all the body knows what to do is say, I'm getting signals. Someone help me interpret
it. Right. And the check engine light came on, basically. Yes. And that's a part of, what pain neuroscience education, which I'm a big advocate of, is just also being and helping people understand when they hear about this stuff, in particular, the vertebral artery being compressed and causing a stroke. That is increasing via the gate control theory, right? The amount of threatening information that goes to the brain, which oftentimes increases the amount of threat and makes the symptoms worse. So I think part of it is also, and that's my reasoning for asking that, which is if your neck hurts, it's probably not the vertebral artery. I mean, you should be safe, you should check, right, but the appropriate clinician, obviously licensed physical therapist, chiropractor, medical doctor, osteopath, is going to be trained to rule this stuff out. So people oftentimes, I do find, are very concerned about having manual therapy techniques in their neck for these kinds of reasons. And I think it's really just very much like, if they're afraid to go swimming in the ocean because they're going to get bit in half by a great white. It's like, well, that happens, but millions and millions of swimmers, it's like, it's a rarity, right?
It's a rarity, yeah. And one thing I always like to tell individuals who have this is that there are more ways than one to skin the cat, if you want to say. Basically, you don't have to have in-range manipulations and things of that way to improve how the muscles and the joints and some of the origin of what's going on to go. So the treatment can be a lot of different ways too. So I have probably two people in my entire career that I treat a lot of upper cervical cranial stuff, and I would recommend no manipulations. It's just they've had a negative response, and there are some connective tissue conditions and things like that was the reasoning behind this. So that's, I've been treating about 14 years. So just to give you an idea on that, but a lot of people don't want that. Some people don't want the pop. Some people don't want the head at different end ranges. So there are other ways to work. And that's something to make sure that you tell your provider, if it's osteopath or a physical therapist or a chiropractor or a massage therapist or whoever, be sure, tell them that, hey, I get more anxiety when that happens, because what we don't want to do as healthcare providers is to create more anxiety and fear. And that's just doubling down the wrong pathway.
And so I'm going to move on to the next piece here that's related to that, is that when you're doing things like end range or manipulations, and there's seems to be two major camps with this. And of course, people kind of cross-pollinate in here, which is, do you tend to think about the changes that you're doing with the cervical spine as more mechanical, or neurological? And where is the bigger influence, or I would say the gold is when dealing with cervicogenic patients? Like, what do you feel is actually happening in there when you're doing it? And of course, we'll talk about exercise too, but predominantly with manual therapy, what's the effect that is occurring in there, or are we looking for?
Yeah, great question. We nowadays we're knowing it's not just a mechanical effect of moving the atlas back in place or C2 or whatnot. Maybe that's happening some. I am not an upper cervical chiropractor. They have some big imaging processes and things that I am just incapable of doing. But generally speaking, we've almost moved out that camp as a physical therapy profession. That camp is still intact. So it really brings up the other aspect of what else happens. And things happen at the neurological level is the biggest thing, right? At the segment, the spinal segment, but also into the brain. Because basically what we're trying to do is kind of stop this stampede of bad people, bad signals coming from these areas so they don't interfere with the normalcy and that should be occurring. So when you move your head and you move your body, you don't get a threat. Your body is basically giving you a threat. I make the thought process that something going into the head like that, either a headache or, since we're talking about dizziness is almost same as someone going to see a doctor because they have a big sciatica pain. Like, that's much different than just back pain. It's giving you a stronger signal and it's pretty angry at you. And we got to figure out how we can improve that. And the reason of the multiple systems and the reason how we can approach it. Because it's multidimensional. I mean, there are tons of papers, much more smarter academic individuals than I am to dive into all the mechanics of what happens with manual therapy. But we do know it's a ton of information now. It's really amazing. It's really cool that we're actually able to study that stuff and find out difference in chemicals and difference in brain activities, MRIs, and just tissue texture and local stuff as well. So, and that's why I think we talk about this, because there's different ways to treat it. Because you can treat it through the muscles, you can treat it to the joints. We like to do both.
And so as you're doing, and predominantly, I would say is that I might be, I don't want to put words in your mouth, but are you starting off from a standpoint of starting with manual therapy to start to work with people? And is that, how often do you see, would you say, just generally speaking, a large chunk or the lion's share of the improvement with manual therapy versus the things that you might have somebody do maybe at home or with a supplemental movement program? Is the manual therapy the thing that really gets people set off in the right direction?
I do. And I think that generally speaking, I think manual therapy, if it's performed correctly, and there's a nice little connection of what you're doing and it's the correct way of doing it, I find if it's truly cervicogenic dizziness, like, you're going to make it should make it an immediate impact. I like to dive into there are some specific areas we like to treat for that. And the bigger picture for, say, an individual who's like, I've had manual therapy, I've had all that stuff, it gives me like 2 days of relief and then I'm back to where I started. That's where it opens up to, well, what is the cause of you needing the manual therapy up there? And that's where a good assessment by somebody to look at multiple areas, either in the jaw, like you mentioned earlier, or down in the lower cervical spine or the upper thoracic spine, of why is it putting a lot of stress in the upper cervical segments to make it move too much and get those signals. But I say, if you do get treatment by someone, like, absolutely need to address that area, because that's where you're going to make the immediate changes.
Gotcha. And I think that as many times as I've heard somebody say, well, I got this therapy and it didn't work. And I'm like, didn't do anything. And they go, well, I only got a day of relief. And I'm like, that means it worked. The problem is it didn't stick. So I think that almost anybody dealing with complex, dizziness issues coming from the cervical spine would be absolutely stoked to have 1 day of relief, let alone 3. So,
Right.
okay. And so as you're doing your follow-up work with that, and I think I was kind of getting the hint here that you're oftentimes seeing a lot of these problems coming from maybe C1, C2. What are the most commonly involved vertebrae that you think are the primary contributors or stressful based segments?
Yeah, absolutely. Typically, C1, C2 is probably the major one, but we're going to get a lot of influence from the joint right below that. It's called the root of the spine. That's C2, C3, and that's a lot of the neurophysiological projections. But the way we kind of look at it is usually you're going to have a mismatch within those joints. So the upper segment as well, which is the occiput or the skull connected to the atlas, can be a component as well. So we like to be very comprehensive in terms of treatment of all those versus just being one joint and that's the only way to do it. I think that is what's going to take someone from feeling, let's say, 1 day of relief and then to 4 days of relief or whatnot, to really open up that window of because a lot of these people come in and they just suffer day to day. So yeah, I agree. Like 1 day of relief is a great window. And I encourage people to, because they're like, oh, they get upset that it came back. But I'm like,
Yeah.
well, we just might need to change the plan. Maybe I need to see you sooner. Maybe like, what are we missing that it doesn't stay longer? What's picking at that area? Is it because you get back and look at your phone for 4 hours a day or something like that? What's picking at it that we can't go there? And that's where like seeing someone who can really look at your everyday lifestyle, postures, ergonomics, things like that, and really like make it a very comprehensive approach will get you there. And you guys work as a team. Working as a team is really my thing. It's like, I'm here to help you, but you got to help me to get you there.
Yeah, I would say that for the most part, I tell people the only acceptable outcomes for these complex cases or pain issues is number one, that you don't feel any worse. If tomorrow I get in there and I'm massaging tissues and tomorrow you don't feel worse as a result of what I did and you feel the same, that's a win, because that's right. Just starting to impact that area. And I'm very conservative with any of this stuff because people have strong responses sometimes to things. And even with massage work, and I'm not even doing any joint manipulation. So I think that that's a big one. And there's a lot of anxiety for people on session number one to just say, hey, this person is not going to be too aggressive with it and not aggravate things.
Yeah. And I agree with that. I mean, I tell people that if your body is finally giving you a signal that is making you feel lightheaded or dizzy, it is pretty angry at you. So if you find the source of that, they're typically going to be much more angrier than you just waking up with a crick in your neck kind of thing. Like that's your body saying, that's like a level 2. But if you're getting dizzy, like that's a higher level of a signal, So I tell people like sometimes we'll be able to knock it down tremendously, but give it a little bit of time. We need to let some things to adapt and you build that trust. If someone's suffering from this, find someone that you trust and that feels confident in working with you, listens to you, because it's a two-way street almost with some of this. Because I always tell people like, don't be afraid of the neck to treat it, but respect it. It is a very sensitive area. I think we sometimes take advantage of how lucky we are to be able to put someone's head in our hands, if that makes sense. And
yes.
And actually they are trusting us laying there that we can work with them and do what we need to do that will ultimately help them. So I find it very gratifying every day that someone trusts me to do this. And I think that's something that allows me to keep moving forward and really help that listening component back and forth, because that's where you're going to get more and more your outcomes.
Yeah, absolutely. And being very vulnerable, to somebody manipulating an area that's so, I would say, close to home, which is the brain, or what we perceive to be the home of our consciousness. And if you're already feeling threatened and having a sympathetic response just from, not necessarily having a good therapeutic alliance with your practitioner, that's a bad place to start. And especially when we're trying to reduce threat, right?
Right, exactly.
And I do have one more mechanical question from you. I know this is probably going to take a whole nother hour, but what is, and I just had a PT that came on and talked about this, the relationship from what you see of occlusional imbalances to some of these cervicogenic issues. And of course, this can swing so many different ways, but are you able to, and really what I'm interested in is the degree of improvements that you can oftentimes get just by addressing the cervical spine versus having to wade into the waters of dealing with occlusional imbalances to try to get an optimal outcome.
Yeah, this opens up like
I knew it would. I knew it would.
The way I think of this, generally speaking, if someone's coming in and we're thinking cervical dizziness, I would attack that area first, and see if we can knock down the intensity, duration, frequency, et cetera, et cetera. If we get to the point of, hey, we're not able to get this thing taken care of 90%, 100%, let's open up the clinical impression of what are we missing? What rock isn't unturned yet? And go into the orofacial region. I typically just said, this is what I do. I typically treat that and I assess that typically day 2 with this, just so I don't leave any rocks unturned. So generally speaking, if you talk about malocclusion, sometimes as a massage therapist, a chiropractor, a physical therapist, a lot of them can work that area and just see if it impacts it. We have assessment tools, we have manual therapy tools, we have exercise tools that can help that as well. If you get to the point that you're like, I think that is a major area, but we're just not getting what we need, that's where that clinician probably should have a team of like, all right, well, do we have a TMJ dentist local, which, we have a lot of that. That's like, I think you might need to consult with this person. I think there's a huge input going in. So that's almost the way I look at it. I have a real simple test in the clinic where I use tongue depressors and I get somebody to clench down and ask them where they feel it. And if they don't feel the back of the molars hit, or if it doesn't feel like a little pressure in the joint, or if it's asymmetrical, sometimes I'll use a 1 millimeter tongue depressor and I'll kind of fill in the gap a little bit between the tooth on that side and see if I can create symmetry. And if we find some major findings with that, then that is a big flag to me to go ahead and make that educate the person. I think this is a major component or something that will help you. And that's my clinical test. I don't think there's a lot of research, particularly with that. To be honest, I mean, I have had people that it'll be 3 millimeters off on one side, and they're like, "Oh yeah, that feels great," and I'm like, "I can't help that. That's too much of a difference. Let me send you to orthodontics. Let me send you to my TMJ guys to tackle that." So I look at it almost as a component where if you're suffering from this and you're in someone's office and they have knowledge of orofacial work and therapeutic massage and manual therapy, see if they can assess it and then see if they feel like there's a component. Because a lot of patients, the patient's going to tell you a little bit like, hey, when I chew or if I talk too long or I'm waking up with a headache in the morning, I'm just tight in my jaw, then those are little avenues that help a little bit more go down that pathway. So I always start the cheapest route, like see whoever you're working with there before you get into these neuromuscular dentistry, before you get into the maxillary appliances. You're talking about thousands of dollars, or orthodontics, thousands of dollars. So I always say, look, man, I can tackle this. I can tell you if I don't get you better, give me a few sessions.
And that is a rabbit hole. And that's kind of been the problem, is that I see a lot of apprehension with people about dental stuff because it's so hard to tell. And again, you're the expert on this, but I don't think I've ever heard of somebody being like, unless it was an overt case of having TMJ issues, most of the time it's just like, it's the chicken or egg, right? You correct the cervical spine, the bite gets better. But like just having to go, hey, I got to send you to the dentist and look at all your teeth. And people are like, because we all understand how that goes. And I don't know if you immediately get any improvements like direct manual therapy to the neck. And that's kind of what I was reaching for here.
No, you don't. And if you've known people have to have orthodontics or they have to have some sort of maxillary device or mandibular device for either just TMJ itself or to correct that, you're looking at months, 4 months,
Yeah.
6 months or some change. And I don't like waiting around for that.
No, it seems like you can get it done faster, especially with manual therapy techniques directly applied to the problematic areas.
Right. Yeah, I
Okay.
agree. I mean, because you ought to be able to knock down the otoneurological signs very quickly. That may be kind of fixing the musculoskeletal stuff that might just kind of be picking at it over time. But typically, I don't have to treat the jaw to get the dizziness better. Sometimes you could, but you definitely need to treat the neck.
Okay, very, very good to know. That kind of takes care of one of my next questions, which I had asked as well, which was the timeline to start feeling improvement. And obviously, usually, if you're doing the right stuff, and barring that you've been excluded from some of those complex conditions, and it is indeed cervicogenic, it's pretty rapid that you can influence it. But then comes the work of getting it to sustain. So what is kind of like the long-term prognosis in terms of like when you're doing your manual therapy, sending people home with techniques and so forth, barring that they don't have too many influential factors that just keep kind of knocking them back into their pattern. Are people able to basically well sustain themselves in the long run with just exercise and just taking good care of their lifestyle?
Yeah. I think if it's truly like a cervical component to their symptoms, I mean, a lot of times it could be 3 visits. I mean, and you'll be great. But I think finding out, improving their posture, improving some of the mechanics, getting them into different routines, either yoga or whatever you find that you feel like it's picking at it. And that's just a good discussion that's wholehearted with your clinician and really trying to work together as a team. I find that the good cases, those are it. Now, we do have the other end of the spectrum where these individuals are much, much tougher. And that's where you really need to make sure that you consult with the vestibular therapist, make sure there's nothing going on that component. Or you need a little bit more specific type of exercise component, especially if someone's had some like a trauma, like they maybe were surfing or something, their head hit the bottom of the sand in the ocean, and they started with neck pain then. And you're talking about, all right, well, we've got a little bit different than it just kind of arising without a traumatic event. Traumatic event typically is a little harder. It depends on what it is, especially if it was some sort of head injury. So that barring aside, those are a little tougher to give. I always tell people, give me a few sessions, I'll give you more prognosis at that point. But if it's truly like you just woke up and you're having some of these symptoms and weekend precipitated from the neck, you ought to knock down the actual otoneurological signs pretty quickly. But then you've got to, from a patient standpoint, I really tell them, like, you don't want this to happen again. Let's find the root, the cause of it, and get you to attack that. And that's the part that I think from a home run standpoint they can do. And then they learn their signals. They're like, kind of feeling a little something before it really shoots through the roof. Go and do this that we found to be effective. See if it knocks it back down. And that's ultimately what we try to do.
That's a great take-home point. And of course, for those of you listening out there, everybody's just, wide variety of different types of scenarios, which does make these kind of podcasts a little difficult because you do have people that are on the severe end of these types of issues. And then you've got people with just kind of basic symptoms and things that like something they've been dealing with that maybe isn't destroying their life, but is something that is obviously problematic. But, it's good to hear that, as always, and as part of the reason why I'm doing this and interviewing experts like yourself to help people realize you're not hopeless. There are experts out there who specialize in these things, and you're hearing it from the horse's mouth saying this could take as little as 3 visits. So don't think it's going to take years to get better from this if you're going to the right person and you're getting the right treatment for what you have going on. Yeah,
absolutely.
Awesome. So what I do want to talk about here also is the kind of different options, because almost always as a result of these interviews, people are going to go, great, what do I do now? So first and foremost, you've got a couple of different options out there. And I think you've got some training for clinicians and you've got some things that are more based on clinicians, but do you have other options also for people who are on the, consumers of people who are actually dealing with these issues as well?
Yeah, we do in person. We own a clinic and we do treat people in person. Sometimes people have traveled several hours to come down, and we kind of have a program where they can consult with me and my wife, and we address all of these systems. They could spend the night and come back. So we kind of have that itself. We do some consultations virtually as well. And a lot of that is to listen to your story, kind of be the coach to help you find what's missing. And I can't obviously put my hands on you through telehealth, but it's a really good, we found pretty good results of really helping someone find people individually that are close to them as well, that maybe have some of this training. And those are our big aspects that we have to help folks.
I mean, this is something that I remind people of constantly, is that if somebody's seeing a local therapist that really wants to help somebody out, but they're kind of not at the knowledge level that you are on this, I mean, geez, is it possible to do a telesession and then chat with their therapist about what to do manually? I mean,
we've done that.
Yeah.
We've told them, hey, they will come back to me. They're like, I'm worse. And I say, well, tell them don't do, we right. Connect the dots. Yeah, exactly. We've had that happen. And we are coaching them to really find out, like, if the therapist is working the upper neck and they're worse, like, something is not right for it to be worse. Just like you said earlier, it should get better. So we kind of got to think outside the box of making it better.
Yeah. Books. Let's talk about your book real quick. What's the book called?
This is the book I have out right now is our Cervicogenic Diagnostic book, and it's via the optimal sequence algorithm. That's we call it optimal sequence because it's a stepwise progression of helping the clinician diagnose cervicogenic dizziness in the correct format, meaning the diagnosis of exclusion, like you spoke about earlier. Like, so if someone comes in, you shouldn't think just their neck. We need to rule out all these other components or have them as a double entity as we work on the neck. It's our diagnostic book. This is what we created. It's several algorithms in there to rule out something spontaneous dissection, vascular, like we spoke about earlier, instability work, peripheral disorders, myelopathy, things of that nature that are kind of a little bit more scary that we need to make sure that you get the right help with. And then we dive really into the neck component, cervical component, and basically the optimal sequence of how you should address someone who has potentially these symptoms, like we talked about earlier, the symptoms, the range of motion, what precipitates it, and then go into specific areas from a manual therapy standpoint, and then special tests, the head relocation tests, and like a lot of people think of these lasers and things of that nature with basically looking at balance of the head, proprioception of the head. We discussed that as well. And we help people determine like how effective those tests are or not effective those tests are, or if you need those tests, or if you don't need those tests. So it's a lot of detailed information. It's 300 some plus references, I think 300 some pages, I think now, something of that nature. It's a heavy hitter.
Yeah, I would say just as a testimonial, because I have the book, and that's kind of what's kicked off me reaching out and contacting you also, which was it's extremely thorough. And I just have to say kudos to you and your wife on doing such an amazing job on this. And to me, I read these things as not a diagnostic practitioner, but to be able to understand enough that when people come in, to know if they need to be referred out to what types of practitioners and what types of topics might we talk about. There really is no downside, I think, to any practitioner, even as a massage therapist, being more educated on the issues that you're constantly seeing with people to be able to help them in any way you can or support their therapist. And if you're a clinician, chiropractor, physical therapist, or even if you are doing massage work with complex cases, this is a book to get. I mean, you need to know it. And again, I can't fathom a PT or a chiro that is not treating these patients on a regular basis, not having a resource like this book.
Oh, well, thank you. Yeah. And,
it's unbelievable.
Appreciate it. It's interesting because you can go and find some articles out there, but of course, as you know, research article wise, you're limited to space, you're limited. And we don't have that. We don't have these limitations with it. So it's basically what you should do, but then how you should do it. We have objective and subjective measures, exactly what the outcome should be with every test. It's thorough. It's a heavy hitter.
But that's what you want. And that's the thing that I always am impressed by, which is like, okay, I don't want just piles of research. Show us what to do. by
Right.
somebody who's done it, who's done the grunt work of putting all of that stuff together and synopsizing it, writing it English, and go, this is what we're going to do. And I think that that's really what people are after, especially busy clinicians that treat lots of different conditions. That's 6 months, 2 years more of just trying to sort through all of that information and research out there. And I just think that most people don't have the time to do it unless that is 100% their focus. So you guys out there doing the heavy lifting for everyone is doing an amazing service. So again, I appreciate you, and make sure you tell your wife, thank you very much as well.
Absolutely. I will do. Yeah. Well, thanks
Awesome.
for having me. This was a phenomenal. I hope it helps a lot of people out there and gets them thinking of some true data, some information on this topic, and really help people get better. That's what we're here for.
Absolutely. And I'm going to have you back here soon. In the meantime, those of you listening, don't worry. I will have references to links and so forth below this podcast so you can get access to all the materials and to reach out to Harrison if you have any questions and so forth. So I'll wrap it up here. Thank you so much for your time. Greatly appreciated. And those of you out there, we'll see you next time.